Thank you, Ryan, for that nice introduction. What we're going to try to do today, and this is really going to be informal. I've got a bucket load of slides. Can you sort of tell me how to advance this thing? Or there's probably a trick up here. Is that it's going to be really informal. I'm going to go through what is at least my formula for putting together a successful NIH grant, and I will just say that NIH grants are not the only grants out there. They're just the ones that, at least in the U.S. setting, seem to be where you can get a fair amount of money. We're going to get a little timer here. So I'm going to just go through some of this, but I'll also point to some other sorts of areas. But I think that the principles are really the same. And so, which one's the clicker that moves me forward? There's a trick here. Trick question, or the left one? Oh, that one? Okay, great. So one of the things that, and by the way, I don't always follow my own rules, so I will tell you where I deviate from them, but the first one, that I break the rule. I don't like following rules anyway, but is to start early, make a timeline, and stick to it. And I will say that in principle, I do stick to that, but I do it in a slightly different way. I spend a lot of time sort of starting early and really making sure that I understand the literature so that I can write with facility. Now, we all know that we all have different writing styles. Some people just say, I've got to get something on paper, and then I'm going to sort of move forward, I'm going to tweak it, I'm going to revise it, and stuff like that. That is one phenotype that's out there. I'm the one, which is the opposite phenotype, where I have to get all of this stuff done, and so it looks like a whirlwind at the end. And if you want to drive your staff crazy, you follow my phenotype, because it makes them crazy because they don't think you've done anything all along. But I would say that a really good principle, and you have to know yourself and how you do that, is to at least get something down there, and do know that you can revise it. Because sometimes people will say, can I at least see what you're thinking? And it's good to be able to have that. Make sure you give yourself plenty of time. The submission process, at Yale, it's a fine-streamed machine. They get it through very quickly, and I'm thankful, so I turn in stuff like the day before. If you're at an institution that has not dealt with all the bureaucracy in the forms, make sure you get stuff like a week or two in advance, so change your timeline. Just, sort of backstamp it a little bit more. And then really try to have people look at what you're doing. Float by ideas, get them to sort of weigh in. And especially in implementation science, as Luke pointed out, that you're really dealing with a lot of people from different disciplines. So let them weigh in on some of this stuff to see if maybe you can frame things slightly differently. And I think where you have time for an internal review, it's good to get that. Many of the people who do these internal reviews have been on study sections before. They're going to have some really good ideas about the way that you present things that you might have overlooked. You're sort of oftentimes limited by either like a 6 or a 12-page, sort of restriction. So get them to sort of help you think about what you might have missed out. When you're writing, the clarity with which you write is absolutely critical, and it needs to be linear, one thing after the other. And my sort of background is sort of twofold. I was a science major as an undergraduate, but I was also a social science major. So I was both biochemistry and Spanish literature. And I do think it's important to, even though you will write mostly scientifically in these grants, you need to tell a story. You need to be able to tell a compelling story as though you're sitting down and talking people through why that this is important. Because if you don't tell the story, the reviewers are not going to be enthralled. And one of the things that I will point out, and I'll hit it time and time again, is when these reviewers are reviewing grants, it's not like me sitting down and I'm going to look at one grant. I've got all of my own work to do. I'm going to get slammed with 10 grants. I've got to get through all of them before the committee. I'm reviewing the grants oftentimes at the last minute. And if somebody gives me a grant that is tedious and painful, and I have to go back several different places to look for things, I'm going to dismiss it. I'm going to be really unhappy about giving it a positive score. So let people read it with some enthusiasm. And I will say that there's another phenotype out there who they just want to give you solid facts. I think that's a perfectly good way to do things. It's not my style, because I recognize that as a reviewer, I want someone to compel me early on. And make sure that your passion about what you're doing is coming through. And if you're writing a grant because, I got to put in one more grant, there's not going to be much compassion there unless you really feel strongly about that. So as you're telling the story, you need to say why this is important. So importance is a really important factor. If you're going to talk about something that affects 200 people in the globe, it's not that important, all right? You sort of really need to go at why that this is a big deal. And you don't have to go through, like with HIV grants, that there's 38.4 million people affected. You don't have to go all of that. You can say that it's one of the top global health concerns, and you can really get at that point to really start to get to some of the point. What you really need to do is you need to review the literature, and you need to know what's missing from the literature and what was the innovation. So are you able to sort of say, this is a critical piece that is missing? Like for instance, with COVID, we had all of these ways of doing things. We didn't have new things to do this. So with implementation science, what might be new ways or disruptors or something like that? So you need to be able to tell that story. Make sure that whenever you're reviewing the literature, you do it in, maybe perhaps not in the sort of classical full systematic review, but you need to do a pretty good solid review. And where there is evidence, use the systematic reviews, the Cochrane reviews and things like that to sort of set the stage. But if you're trying to read between the lines and show that there's perhaps a reason for why it should be done differently, a different strategy, or the need for tools as part of your implementation, bring that out. So in other words, if you have an intervention in which the fidelity is 55%, and you know some idea about what those are, what are you going to bring to the table to sort of build that into your program? One of the things that you need to do is you need to think about where is your innovation. So are we taking something that's from, let's say, the place like the US with it's heavily resourced and we're going to do it in sub-Saharan Africa, so we have a contextual issue that could be there. Are we working with a different population? PrEP may be sort of really been very effective in rolling out with MSM, but maybe perhaps not with people who inject drugs. And are you using new strategies that are helping you do things differently than you were doing before, and in ways potentially that are more cost effective, whether you're saying, all right, we've traditionally had physicians do prescribing for ART, now we're going to maybe work with community health workers. We're going to find a way to really bridge an implementation gap. And then part of what you need to know is what is your concepts application? Can it be applied in the setting? Is there the ability, is there feasibility in doing that? And can it be generalizable? So if you're doing something that's totally niche, that doesn't have some applicability, I often will say, I'm doing a project in some, lower middle income setting, but the reviewers are going to sometimes come back, especially if the funders are from the US, and say, what is the applicability for doing this? And you could certainly make the argument that in a high income setting, you might have a lot more resources, but if you could apply some of the lessons that are happening elsewhere, I think task shifting is one of the things that comes to mind. This is something that can be applicable in a number of different settings, and even if it's not applicable to a high-income setting, what might it be in terms of what I call the global south, in terms of being able to scale up and do in many other sort of places. Now, you need a great idea, and you need an important topic, and it really needs to make sure that you set the stage right up front for what is the major overarching purpose of the study. If it happens to be Luke, he wants to get more people diagnosed or more people, or say diagnosed, whether it's the case finding or something like that. It's got to be something where there's really a sort of a gap in the literature. And then one of the things that I like to do is I sort of go back and I always retool two parts of my grant application. One of them is my abstract. So your reviewer, remember, they're going to have probably 10 grants. And they're going to want to be able to see things. By the way, all my slides will be available. If you'd like to take photos, that's great. You can post them to Facebook, but you can have my slides. They're all free. And you can have them, you can reuse them. So everything is open access as far as I'm concerned. But what you sort of need to do is make sure that your abstract is going to tell a really important story. You have 30 lines to get this right. And then you get one page of the specific aims. And if you can't excite them, at least from that part, you're not going to give all the details and those sort of things, but to really say that you're doing something important and in a new way, innovation, a new way, then you will lose them at that particular time point. So make sure you go back and always retool that, even if you write those things first and you go back to them. The other thing is as you're doing your specific aims, your aims need to be related to each other. So for instance, oftentimes in implementation science, we might say we want to understand the barriers and facilitators, and we might use a socio-ecological effect. So that might be the first step. So that could be aim one. Aim two, could be, what's the core of your work? We're going to implement this that will potentially address and overcome, those barriers. And then how will you put those things together in a way that will take you to sort of a new, field of study? And so those aims need to be oftentimes linear. Remember, if you have one aim that is going to completely undo your second aim, because the findings may actually undermine that, your reviewers might say, how are they related to each other? What might you expect some of this to be? And so you really need to make sure that they are sequential. Sometimes the aims look slightly different, and you have to sort of look at those in a way that it doesn't seem that unrelated, but you might want to turn that into. So for instance, if your third aim is a cost effectiveness, we will use data from aim 2 to sort of populate the model estimates for X, Y, or Z, or we will collect cost data to do this. Try to always tie things together, related to the aims. And the place to really sell the whole grant application, as I said before, is going to be the 30-line abstract and the one-page specific aims. Now, there is some impact and focus that's going to be important. And your impact, which is what you're going to get a lot of your points for on your grant, is going to be, is it highly significant? Like I said, you can't do something with 200 people. It's got to be something that's really population important. If you're going to focus on the cascade that STEM puts for whatever it is, whether it's a non-communicable disease, remember each of those cascade things are your processes. And if you're going to start out with a place where there's very little implementation gap, for instance, if you look at the HIV cascade, the implementation gap between giving antiretroviral, or I should say adhering to antiretroviral therapy and viral suppression is typically very small. Focusing on that piece won't make a difference, but if you've got a 50% implementation gap between diagnosis and treatment, that will be the place where you probably want to have the most profound impact. And then the other part of it that can undo your entire study, and you'll hear from Denise Esserman, is it's got to be feasible. And if Sten was talking about these studies with 150,000 people, you really need to make sure that you can sell the reviewers on the idea that you're going to be able to get to those 150,000 people in order to do the work. Sometimes you can use administrative data, which means that you can look across kind of population data. You just need to make sure that the quality is good, so you can do something that is a little bit more finite. And then, so the other thing is that I think sometimes gets people into trouble is you have to sort of make sure that your investigators are the ones that are going to fill those one of those grant or expertise gaps. So for instance, I might be identified as a person who's board certified in infectious diseases and addiction medicine. But if I start saying I'm going to look at cancer control, I'm going to need to make sure that there's somebody else on my grant who does oncology or the epidemiology of non-communicable diseases. So you need to make sure that you've got the expertise sort of covered there. And then one of the things that I oftentimes like to do, and this has been sort of a more recent lesson, is that the NIH, you can get a score, and you can score in the 4th percentile, which most people would argue that is a slam dunk. That is an incredible score to get. But if you don't hit a priority area that your institute is interested in, they can go over your grant. So one of the things that I like to do is, as I'm writing my aims, I like to sort of talk to my project officers for them to say, oh, this is something that's interesting, because if you work, on average, these things take about 300 hours to write a grant for most people. And if you're going to spend that much time, you want to make sure that the people who are going to review your grant are going to say, yeah, we think it's important too. Because what they can do is they can come back and say, this is not really a high priority for us right now. And I hate for you to spend a whole lot of your time. So you might need to sort of retool that. And I've had that happen with grants that scored nearly a perfect score, where they have gone over and they've decided that for whatever reason, that wasn't a high priority for them. So don't write just for yourself and the reviewers. You got to get through the reviewers, but eventually the people who make a decision around funding have got to be interested in this as well. There are 5 areas in which you're going to get points for your grant. And they don't say you get 10 points for this, and you get 8 points for this, and you get 40 points for this. But the places where you're going to get your points are going to be, 1, is it significant? We talked about thinking a significant problem. The innovation is you're going to do something different and better, perhaps, than anyone else has done. And you're going to get a lot of points for both of those. If you don't get past those two things, the rest of it probably isn't going to matter. Then the place where the reviewers will probably pick you apart is in your approach. And this is where you have to dot every I and you have to cross every T. So in other words, if you are going to do things, your approach has got to be solid. Your study design, whether you're going to use a cluster randomized trial or a step wedge design or a quasi-experimental thing, you sort of really need to justify, you need to make sure that the data that you're going to get is meaningful in terms of being able to measure that. And this is where you really need probably your external reviewers to get a little bit more tedious around taking a look at what you put into that particular part, because they're going to come back and they review it and they'll say, well, what about this or what about that? So sometimes being able to sort of plan in advance what those contingencies are. And you know, when people write these grants, by the time that they're done with their 300 hours, we think we've all designed the most perfect, trial or the most perfect study. Our reviewers will prove us wrong every time, that they will find imperfections in our studies. And the more that you can sort of head them off, it'll be better. Now, one of the problems with these grants is there's oftentimes a limited page. So there are some places to get some freebies in there. And I call the freebies, like in your budget justification, you can write a lot about, oh, this is Professor Luke Davis, and he's done this and this and this and this, and so we can establish some expertise that might look a little bit differently. So we get to build that into our grant without filling the pages. Our human subjects is a place where we talk about how we protect people from any of the problems, but we can put a lot of details about how we're going to do that. We will ensure that we will screen them doing X, Y, and Z in the following ways, and you're giving the information, to the reviewers that you've thought about some of the things that you may not be able to contain in the 12 pages, at least for an R01, or 6 pages for some of the smaller R grants. The investigative team, as I said before, has got to really cover the areas of expertise. One of the things that I strongly recommend you do is not include everybody in the kitchen sink just because your boss or your chair or somebody else wants to be acknowledged in some sort of way. There are some things that you have to do in order to massage some of that. But if you invite everybody in the kitchen sink, people will believe that your team is too unwieldy, or there's so much overlap between that. And especially in places like Malaysia, oftentimes the salaries are fixed, so it's not like you do 10% of your effort or 20% of your effort. But in the States, we have percent effort that we look at, and if we're paying for 5 or 7 different faculty members, that becomes a huge amount of money, and people will think that that is wasteful, and so that may sort of get reflected later on in the way that they review your budget. And then of course you have a whole section that's sort of unlimited, which is your environment. Where are you doing this? You're at the University of Malaya. We've got 15 different departments. It's ranked number 52, whatever these sorts of things. We've got expertise in substance use. We have expertise in HIV. We have substance use in aging. We have all of these sorts of things. We have a big library. So, some of those things are other freebies that you can say. We have clinical research sites so that people know that some of the things that you're going to do are going to be feasible. Let's start to break some of this down a little bit more. So the research strategy, you have your first page, which is oftentimes the specific aims. You sort of set the picture, you give the 30,000-foot view, and then you become very specific with your aims. So your significance is really from reviewing the literature, your systematic review, if you will. How many people have sort of read articles in the Lancet? Most people have read. One of the things that I think the Lancet has really taught me is they have that section at the beginning of the paper that's called the research in context. What did you know before this study was done? And that's how I sort of think about my grant. What is the lay of the land? What did you learn from this study? This is what I'm going to do in this research project, and then what are you going to do with that? So what does all this mean? How do you put it into the fields that are going to change the guidelines? You really want to you don't want to just do research for the sake of research. You want to do something to change the way that, that care is delivered and that people will do better. The innovation is what's new, what you're doing that is completely different than other people have done, and how will the science change. So if you show that task shifting gives you the same clinical outcome, but it's cheaper and it's more accessible because you have more staff, that is a benefit. You may not actually show that more people go on to ART therapy, but they do it cheaper and they do it more efficiently. And so these are the kinds of things that you can look at. Your approach, don't overpromise. I'm actually typically somewhat conservative. Be realistic and comprehensive, and the things that you're doing should be stepwise and linear. So there's a bit, I'll show you a couple of examples from some grants to sort of see what some of that might look like. Going back again, investigators really need to be qualified. You have other places where you get to put in some really great stuff about your team. Every single person has a bio sketch. And there are a couple of different ways that people do it. Some people will actually say to all of their team members, please just send me your bio sketch. I can tell you that if you just ask people to send you a bio sketch, they're going to send something from some other grant that is not really tailored. What I will often do is I will say, in this grant, I need your expert as, let's say, a TB expert or an implementation science expert or as a qualitative researcher. Please make sure in your 5 contributions to science that you cover these 3 things at a minimum. And so I try to ask them for what I specifically want, and when their bio sketch comes in, I review it carefully for the sections, and then I might ask them to revise it, or I might edit it and send it back and ask them to sort of return it again. So if you just ask, oh, can you send me your 5-page bio sketch, that's really not as helpful as being very prescriptive about what you want for that. And then if you're doing something in Malaysia, like, one of the things that I think has been a really compelling story here is that, there's, huge amounts of, let's say, stigma among key populations. And so what you have is an opportunity to say that in one of the most stigmatizing settings for HIV care and delivery, with things that are criminalized both in secular and Sharia law, we are going to do this, and this is basically the worst, the toughest case scenario. And if you can overcome that, it may have some applicability, let's say, in another place where there are criminalization laws. I know that recently Luke and I were talking about some of the stuff around criminalization of men who have sex with men, and they've just enacted some laws in Uganda. And so the applicability in a place with a huge HIV epidemic has great implications. So sort of think about why this environment might have some benefits for elsewhere. Your budget justification. I probably shouldn't say this, but I will say, pad your budget a little bit. The NIH they are legally allowed to make up to a 24.9% cut in your budget. The Congress has actually stipulated that they cannot reduce it by any more than that. In general, they're going to reduce your grant from anywhere between 5 and 15%. So I say, in general, pad by about 10%, because they're going to give you a cut. I mean, I don't think I've ever had a grant where they haven't cut me somewhere. So a little extra padding, does not hurt. You can think about where that is. There are no page limits, so for each person and for everything that you're going to spend money, explain it out in detail. We've got 240 subjects, and they're going to come in 8 numbers of times. You're going to get paid this much for this. That actually then provides the readers with an idea of how you're going to do your work. So that's a freebie, and that you don't put that into the sort of the main part of your body. You get to expand on people's expertise here. And I would say that your timeline, which is a whole other section of the grant, that's another free page, is where you get to put in a lot of details. We're going to do all of these things, and I mark it up with one of those like Gantt-like charts, oftentimes in order to show what that timeline is going to look like. With your approach, and this is what we would call in a paper typically your methods or your study design and all those sorts of things that are part of that. Make sure that the questions are answerable. And unfortunately, we didn't have Denise's lecture before this, but one of the things that you want to do is you want to make sure you choose the right study design. Now, we oftentimes love to have the holy grail of study designs, but in order to answer some questions, you may not need the most kind of rigorous study design. Whatever study design you do, however, You want to be as rigorous for that and controlling for all of the known biases. So if you're doing something that is like a time series or something like that, you need to know that what are the limits to that. That's going to usually be secular trends. Sten was talking about the trials, and all of a sudden they changed the international guidelines. Boom, that will bias your trial. And so you need to sort of make sure that you're controlling for those sorts of things whenever you're doing that work. If you're using some technical things, why is this the state of the art? Why is that the best part that's there? Are you bringing some new innovations? Whether you're designing an app using sort of artificial intelligence or something like that, this is the wave of the future. This is some of the hot ticket items that are sort of being done. What you're going to deliver, what you're going to get from each of the interviews and stuff like that, be very specific. I am going to collect, self-reported data. I'm going to validate that with some kind of database. So be very, very specific about ways that you can measure and alternatively measure if you think that, let's say, for instance, there might be self-reported bias in what you're doing. You can't overpromise. If you take a look at it, one of the things that reviewers love to say in order to sort of take points away from you, it's this damning phrase that says, it seems overly ambitious. And I have to tell you, I've had this written into my grants. Sometimes the reviewers are kind to me. They'll say, the grant seems overly ambitious, but Dr. Altice seems to have a lot of energy. And so they'll give me a pass. But not everybody gets those kinds of passes. And so don't overpromise. Don't try to do everything as, that is and the kitchen sink. You can limit your scope of work because oftentimes, unless you're asking for, approval to spend more than the amount that's available for the grants, you can't do it. If you're doing an R21 and you know that over the course of 2 years that you're going to get $275,000 and you're trying to propose something huge, the reviewers are very experienced. They're going to say, there's just no way you can do that for that amount of money, or there's no way you can do it in 2 years. So really make sure that it's reasonable and that overly ambitious part does not come into their language. One of the things that happens when your grant is reviewed is oftentimes, in fact, typically there are at least 3 reviewers. Not all of them are going to have expertise in your area of content. So you need to be really clear, and part of your job is to educate the reviewers, all right? You're going to have some people who know way too much information, and they're going to say you left out stuff, and you're going to have other people who say, but I don't really understand why you're going to do this. And we've all gotten back review comments where we sort of bang ourselves on the head and say, why didn't they get that? And it's because we did not write to a broader audience. One of the reviewers might be a biostatistical expert, but they know nothing about, let's say, the details of HIV and addiction or something like that. So you really need to spend a lot of time educating people, and I do it through repetition. Things that I think that might be tough concepts, I might hit it in the abstract, I might hit it in the specific aims, and I might hit it a couple of times in the approach, or even again in the human subjects, where I've got some time for them to be able to see these concepts. Assume that they don't know what you know. It's kind of like whenever people are giving a lecture, you're given a lecture because you probably know more than everybody else that's in the room about a certain topic. Really assume that the other people do not know as much as you do, and so you have to really be linear and walk them through the process. One of the things that I like to do is I create figures. And if I can tell the story, what is the expression? A picture paints 1,000 words, all right? If you can show very, very interesting concepts by creating figures that really show people something that might make it more feasible or more clear. I know that I'm a visual learner. Most people who are in the medical field are visual learners. This is a terrible slide, it's full of words, right? But if you can put a figure out there where you show the entire study design or the timelines and stuff like that in a way that's easily interpretable, it's kind of like, it's like implementation science. Can you do it faster? Can you review this grant faster? And you can see all the stuff right up front. I use outline forms and I italicize really important concepts, or I might actually write an area around significance. Let's just say, the biggest implementation gap is on, let's say, linkage to care. And then I might sort of summarize either in italics or in bold or something like that. Therefore, it is crucial to address this gap. Or if I don't think it's the biggest one and I need to go earlier, I say it's important to address this gap before we can address that gap. So give them something to hold on to that will actually show that it's helpful. I am probably more guilty than I should be in terms of using acronyms and abbreviations. One of the things that I do to overcome that is I create a glossary right at the beginning of my research strategy where I put common abbreviations used in this proposal so that people can go to something. Obviously, always you spell it out the first time that they see it, but try to use really common ones if possible. I will sometimes write with abbreviations, and if I have some extra space, I will go through and I will do a check through it, and I'll spell them all out because you're oftentimes limited to time frame. I would say that if you're using more than 10 abbreviations, you've probably got too many in your grants. People are going PWH and PLI-HIV and OST and OAT and all these other sorts of things, and they're constantly going back to that. So be really careful about doing that. And then what I call strategic redundancy, re-bring themes back up a few times in there to remind people why you're doing some of the things that you're doing. And then I would say the other thing that's important, and this is from my years of being the editor of a yearbook and the school newspaper, is the way that things look on a page actually makes a difference. And so break up some of those words. I mean, you can think about the density of the words. I mean, we've all read books where we have like slightly bigger font, slightly better spacing, and we feel more comfortable getting through that. I mean, when I see a book that's like, 9 font and it's all tightly strung together, I'm like, I'm really, it's daunting for me to think that I'm going to be able to get through that. So think about the way that things might be visually appealing. And I'm going to show you some examples in a little bit more. So one of the things that I do in order to break that up is I create tables or figures that really enhance the grant. Do not just copy a figure, from, with slides, we all take things out of papers and stuff like that, throw it up on the thing. Create your own so that people know that it's unique to what you're thinking about. So, if you want to put in, that 17-year odyssey, every single one of us that do implementation science use that slide. That's not what you want to do. You want to create something that is unique, that's there. I create it in as nicest way as possible, and I insert the figure into the grant. So here's an example from one of the grants that we just got funded with. And one of the things that we wanted people to see is we wanted them to see what was happening at each of these implementation activation sites. So this was a stepped wedge design. And so we've got 4 groups that are going to be in each of the steps. And I know we haven't sort of shown what this is, but we wanted to show some comparability and some differences so that people would sort of know what we were doing. And part of what we were doing in this particular grant is we were developing what we call a spoke and hub model. A hub is like an area of expertise, and the spokes are with less expertise, but they're able to reach more patients. So I define them. The hubs are the secondary healthcare centers. The spokes the secondary healthcare centers are the specialty centers. And then the spokes are the primary care clinics. And then I sort of talk about how big these clinics, what's the staffing like, what are some of the factors from an implementation perspective. So when Sten was sort of talking through a lot of the sort of implementation factors, he didn't use the implementation language, but he was really talking about the factors that may undermine or explain your implementation. So when Luke put up a slide with that question mark in the middle of your processes, what is happening in that black box in between that, this is giving you some of the data that you want reviewers to think about. And even with things like this, I remember that one of the reviewers saying, well, not all of these places are, and I had to write back in my response, all these places seem a little bit different in terms of where they're starting at. And I said, well, that's why we use the step wedge design, because each place serves as its own control, right? And so going back and sort of explaining that to the reviewers can be helpful. Here's another example of a table. I think I'm probably using one of Luke's favorite frameworks, the re-aim framework. He's actually convinced me since last year. My last 2 grants have had re-aim, so I think he's sold me on that. That's why I always say I learned something new from his lectures. But what I did was I wanted to make it really clear for the reviewers that each of these elements of re-aim, reach, effectiveness, adoption, implementation, and maintenance. that each one of them was there. I defined what I was going to be counting, if you will, my outcomes, all right? And then we know that these things happen along a socio-ecological model. So we've got the patients, people with HIV. So what does it look like for each of these outcomes for that group? What does it look at the next level, the healthcare, provider level that's happening? And then who are the policymakers at the outer level of the socio-ecological model? And just to remind people, this is really something that's important for, I think, all of you all to take a look at. We didn't go into a lot of detail here, but it's a really nice way of thinking about who the actors are that can either facilitate or undermine your implementation. And so what I wanted to do in this particular grant is I wanted to just make it in real simple terms so that they knew what they were going to be able to sort of expect. Here's another example of a way that I tried to show data that would actually help people out. So this is my specific aim, which happens to be, I was very specific. So remember, the terminology is, I'm going to prove that integrated care, or I should say decentralized care, works better than sort of specialty HIV treatment settings. I was very clear using a step wedge design. I state my study design. What I'm going to do, 4 hubs and spokes, and I define how many of those there are. There's going to be 4 of these specialty clinics, and each of the spokes included 165 public health centers. And I go through all of that and use what the implementation tools are in that, and then I show what I'm going to be doing. So there's like, in this case, you see the control, which is what you measure before you get started. I measure what the intervention is, so it's these 2 particular things, and you'll hear more about NITEX over the next couple of days. And then we have this maintenance phase where we take a look and see whether it's sustained. So in REAIM, remember maintenance, or in EPIS, it's the sustainment. So these are the words that are used. And then we've got our analysis. So we were able to get a lot here. It unpacks the grant, but it shows people right up front that this is our study design, this is what we're going to be doing, and this is what we're going to be doing at each time period. This is one of the ways that I create graphics that are useful to get a point. So this happens to be in the implementation gaps. This is Malaysia, a grant. This just got funded last week, so I'm kind of excited about this. But you've got high levels, at least here. This is an overall, and people who inject drugs. I just used Ministry of Health data and created this graphic, and you can see that the biggest gap is between when people get diagnosed and whether they get ART. And so one of the things that we're doing, and you'll see some work on this, is a rapid start ART model. So we're going to try something to really attack that part of the process, or the cascade, if you will. And so to really sort of talk about where we can have the most. So this was the significance here. If I would have talked about HIV testing and I didn't have as much of an implementation gap, here people would have said, why are you spending all that time doing that? Now, if we were looking at this implementation gap for men who have sex with men, the HIV testing part would be, an important part of it. But this is for people who inject drugs, where they come into structured settings where they get tested all the time, but they don't actually then have the next step. It was what Sten talked about in his study, where they got all these people tested. They put this trailer within a 45-minute walk of every single place. And they tested all these people, but the next part of the gap didn't happen. They didn't link them to care. So here's the example. Here's maybe perhaps a little bit more complex. This is in that same grant here from Malaysia, where we're looking at sort of ways to reduce stigma. But what I did was I ended up sort of creating a sort of a classical model around stigma. And then I talked about what we were going to be doing with regard to the drivers and the facilitators, and sort of built in red the pieces that were part of the grant so that people could see that here is the framework, and this is what we were going to be doing as part of our intervention that might actually have an impact. So once again, it's a way to sort of break up the I on a page of the grant. One of the things that we try not to do is to avoid jargon. I talked a little bit about how you minimize the acronyms. And that's only because you're going to have people from many different disciplines. When I sit on these committees, sometimes I'm one of only a few physicians, so that particular thing, you have epidemiologists, you have anthropologists, you have cost-effective modelers. So it's really important to not use things that are common in your field. Spell it out and be very, very specific about it. Here is my example of how I have about 10 sort of acronyms. I define them, I put them in, in alphabetical order so that people can take 2 seconds just to see what it is that I'm going to be sort of using. There's a few of them here that are sort of, unusual, that are things that we've not commonly used. So a lot of times we use the word, prisoners. That's not language that we are moving towards, so I have to really define this. People who experience incarceration, etc. My intervention is a rapid start antiretroviral therapy. I use that abbreviation. So there's a handful of abbreviations. I'm in the addiction field. People are not necessarily in that, so when they see SSP, Syringe Services Program, they're not going to recognize that. So I try to think about what it is that's important to sort of create here for everyone. Let's see, get to this. So here's my glossary. In either a 6-page or a 12-page grant, you're not going to be able to get everything. Be very, very selective and focus on the most important things. There's always going to be things that your reviewers can find out. Oftentimes, it's better to cut than to cram. I've seen people who will try to condense their font. That's a big no-no. They have computers that measure this now, and they will just send it right back to you. Don't try to, I used to do this years ago, and I've gotten in trouble for it, so I've learned the old-fashioned way. And also, when it's that tight, it's just not visually appealing to the eye. It's just not looking good. Arial 11 is a really clean one. Some people like Times New Roman. Choose your poison and stick to it and stay consistent. This just happens to be the one that looks the best to my eye, and break up the figures. Here's an example of where I break up some stuff. This is going back to the Prue grant. At the bottom of this page is the way that it sort of looks in terms of that table that I showed you before. I put it in at a nice place. You don't want these tables to break over into the next page. So you want to make sure that everything can be visually seen. Here is a map where I talk about the spokes and the hubs. And these are the 4 sites, and I want to give people a sense of what it looks like from a feasibility perspective. That these are the sites that I'm going to be dealing with, and I put the hub and the spoke in each of these graphics so they can see, at least in an urban setting, what that might look like. And here's the next page going in here where I've got like the behavioral, sort of the theoretical constructs that we're going to do for dyadic analyses. So once again, very clean, clear-cut pictures that will actually help people understand what's going on. And oftentimes, if your figure is going to reduce the amount of words, it's worth having it. If your figure is going to create more problems with clarity and you have to explain more, you will eat up a lot of page. So always make sure you judiciously decide between a figure and words without in the way that it's presented. As I said before, people read a lot of applications. Really write. For people who've read Hemingway, I sort of ask people to write their grants like they're reading Hemingway. Very clear, short sentences. If your sentences are spanning 3 lines, find a way to cut it. Make it really, really simple if you can. Use your unique style. We're all different kinds of writers, and I was joking with someone earlier. I'm a dramatic writer. I put in my drama, I make it fun and exciting. Not always the best way. Some reviewers like it cut and dry, but use your style because that's going to be most effective. Don't bore them to tears though. They've got to get through 10 grants, at least 12 pages of science, and then plus the specific aims, it's a lot. Make sure you outline. And one of the things, the reason I use an outline is I will sometimes say, as described in section C.21 or something like that. So I can refer people back. It's not nice to reviewers to make them go back often because then what did they say during that time period? But if it's too much to re-explain that again, you can at least refer to a section so that people can come back to it. Oftentimes when you have to respond to the reviewer's comments in a recompetition where you're resubmitting it, you can say, as described in section C.2.1 or something like that. Your hypothesis needs to be really, really clear. And so, for instance, if your intervention is that you're going to sort of really get people to be able to get care closer to their homes, we hypothesize that people with HIV will improve their CD4 counts through whatever process that you're doing. And that's not very good. That's really vague. It is anything but specific. Let me rewrite that again to sort of be a little bit more clear. We hypothesize that nutritional advice and oral ingestion of 7 daily multivitamins with the recommended doses will correlate with a CD4 count increase of 50 or more. This is before antiretroviral therapy and people were talking about these holistic measures. But it needs to be very, very specific. It's going to improve their T cells counts. Well, if it improves it from 349 to 350, that's an improvement, but it's not a clinically significant improvement. So make sure that you write it with at least some sort of clarification. Some of the reasons that, and this is my take on this, for why applications are not funded, and I spoke to a couple of project officers in preparing this talk, is that the application is poorly organized. I mean, it really needs to be very linear, and I agonize. I will reorder sections if I think that I'm putting the horse before the cart. Sometimes I go back and I think, what is it that we're going to sequentially do? If the work has already been done before, you're just repeating somebody else's, they're going to say, listen, that's already been studied, it's a done deal. I don't think that you're going to sort of build the science basis for that. You can't have a fishing expedition. Almost all grants that are based on epidemiology, with some exceptions, are probably not going to get funded. They're looking more for intervention activities, things that you're going to do to change the outcome. Anything that's descriptive. I'm going to describe. That can be an aim. I'm going to describe, but it can't be the main crux of your grant. And so I would be very, very clear that you're going to have an outcome, you're going to make a change, and it's going to be changed by X amount. Other reasons why is that the objective is not that important. I'm going to get people to come into care more often, but there's no implementation gap, for example. The approach, as I said before, is the place where your reviewers are going to make the most of your comments, and so this is where you have to spend a lot of time getting the details. They need to be convinced that your preliminary data, so if you're bringing in some preliminary data, you really need to show, one, that you really understand this, that you've thought about it, you pulled in some of your own preliminary data, at least for the R01 grants, and that you're going to be able to sort of not have too many methodological flaws. The methodological flaws in terms of your measurement, your outcome, how you're going to do it, how you're going to collect the data, all of those things are going to be important. If you're going to do a study with a population that is really difficult to engage, if you don't show that you can keep them retained in at least 80%, that's going to kill your study design. Almost all the work I do with released prisoners, I don't care how good I am at following up people, I have a hard time getting 80% plus in terms of the follow-up. But if I can look at an objective, I can take a look at, let's say, an administrative database and show that they showed up to an appointment, irrespective of whether I interview them or not. That is a sort of a meaningful sort of ability to measure things. Let me just sort of move through this. I'm going to move forward here. What are some of the funding opportunities? And it depends on how much money you need and how much time. So an R01 is typically funds up to 5 years, $500,000 per year in direct costs, not in the indirect fringe costs. These are the holy grails that many of us sort of shoot for. An R03 is $100,000 over a period of 2 years in low and middle income countries. You sometimes can get by with sort of using these smaller grants. An R21 is 2 years also, but it's $275,000, and it's usually things that I think of as exploratory in order to help prepare myself for an R01. There are these new grants that are coming through that are 5 years, that it's a stage grant, where they call it like an R21/R33, where you get 2 years of planning, you set milestones, and those milestones, if they're met, they give you the next 3 years of funding, or you can do a little bit of a clinical trial. So there are some new things that are moving along. And R34 is a planning grant where you may not have built your protocol, you're not really sure how to make sure your measures are okay. These are tougher grants to get. I've gotten one in my lifetime. I don't know what your experience is, but I find them really hard to get. And I have not gone through a lot of them. I haven't gone for much of those. Training grants are what we keep our graduate students in business with. There's the F30s for MD PhDs, 31 is a pre-doctoral, F32 is a postdoctoral KO1, and these others are for junior faculty members. What you all need to be thinking about is the K43, which is the equivalent of a KO1 for people in LMICs, all right? So you don't have to come from a US institution. You have to be on the faculty here, and they are lovely 5-year grants that give you discretionary money and research money to do your work. And then there are these special program announcements where they have a specific idea that they want people to respond to, and then RFAs that are out there. If you want to be in this business, you can't have thin skin. You know, you have to lick your wounds whenever you get sort of a bad score. And I will tell you that, you know, from my own perspective, I was this young faculty member and I thought that I had the whole world ahead. I wrote my first RO1 and I got it on the first go through. And I was like, yes, this was really great. I got punished for the next 7, where I either got no score or not good enough scores to get funded. And so, you know, most people have the opposite. I got lucky, but I got a little bit too confident in myself, and I got dinged really badly along the way. You have to really stick with this. If you get an application that doesn't score that well, look at those reviewer comments, and I take them to heart. Now, not every reviewer will give you things that are helpful, but at least the good reviewers are going to say, it might have been better had you tried a different study design, and I listen very carefully to that. So, you know, you have to sort of, you know, go through that. They no longer have a limited just 2 times submissions. You do 2 submissions and then you change the name of your grant and then you resubmit it the 3rd time, so there are ways to get around that. And remember that if you are responding to an initial application, you identify, at least thematically, every single major criticism that they had, and I will sometimes truncate it. If you have enough space, I use the entire wording, but you never have enough space. And then I try to do that, and then I refer them. You get 1 page to respond to all the reviews. You can refer them. We have revised section 2.7 to really address the same by increasing the sample size X, Y, and Z. You get just a little bit of time. This is where, you know, your writing has got to be very, very tight in order to keep it together. If your score is not discussed, and they use this term that Denise sort of taught us on the plane ride over here, it has a fatal flaw. When they use that term, really look carefully to see if it's a fatal flaw. It may mean that you have to completely retool your thing and it's a different grant. But if it's not fatal flaw, they're kind of killing you with 1,000 blade, you know, cuts. Then you can probably retool this. And so there's a couple of ways for the reviewers to hurt you. They can cut off your head, and you have to really rethink everything that you're doing, or they can nick you 1,000 times and you don't get a good score, but you have to lick your wounds, and then you sort of need to sort of fix that as you go along. And, you know, I really try to get it back to the same IRG. With rare occasion, do they come back with a worse score? They can, because they're able to look at it. They may not get the same reviewers, but you have a reasonably good likelihood that 2 out of the 3 of your reviewers will see it again. And they're going to care that you thought about what they said. And, you know, sometimes the reviewers are so off, and you have to be able to respond to them in a way that says, we really agonized around this comment, and we bet back with our team, and we come up with something, and sometimes we're like saying you're wrong, but you don't just say you're wrong. You sort of say we really struggled with this, and we went to 15 consultants, and so you sort of need to not piss them off, because the minute you piss them off, your grant is sunk at that point. I've talked a lot about the NIH grant, but I think the ideas around clarity, organization, the way it's visually presented is sort of common for any grants. These are some other places, at least in the global health arena, that you can, you know, get money. And, you know, Sten was talking about PEPFAR, and so they funded these trials and stuff like that. There's a lot of different places to get money, you know, other than, you know, sort of the tobacco industry. I'm happy to take money from almost anyone. I'm an equal opportunity funding prostitute. Because some of these monies can actually create synergies where there are limitations in your funding, or you can use some of these other funding things in order to get some of your preliminary data so that you can be competitive for an RO1. And then there are other sorts of, I've recently been going to the European Union and working with a partner agency in the EU. So I'm working with a German university, and we're going for these EU Horizon grants, which are like $15 million. And you can do this sort of broad, great application, across different areas. So even coming up with partners where you have other sources of money, we happen to be a US institution that's coming here, but that's not who all of your partners are. Everybody here likely has partners in the UK or the EU or other places in Asia, and so I would certainly think about that. Quickly, some of what I would call my quick review with your aims, what you're doing and why, and that's why is it important, and is it hypothesis driven? With significance, why should people be interested? Is it a big problem that is solvable? Use your preliminary data to get you there. Is your approach good? Make sure your methods are very detailed. Is it realistic? Is it feasible? And then every time you do a grant, there's always going to be some struggles. I'm really quite transparent, alternative strategies if X, Y, or Z. Sometimes that's in the human subjects because I'll say, well, if we change and modify this or that in relation, let's say, to a major disruptor like COVID, for example, this is how we're going to protect human subjects. We're going to move them to an online or something like that. I mean, all of us in the NIH moved to, not all of us, but many of us moved to doing all of our follow-up interviews online. And so you sort of need to talk about that. So you can put those contingencies into your grant. Let me just sort of skip through some of that because there's a lot of stuff here that's sort of repetitive. Let me just give you a couple of thoughts on some of these grants. The R01s, you typically have to have some pretty good preliminary data. You're not going to be able to go into it unless you've done some original work. And so, like I said before, these are 12 pages with one specific aims page. A U01 is a collaborative agreement. It's where you might work with 3 different institutions, and you're all working on a common problem, and you're all going to get funded independently to work on a common theme, but you may have different approaches to getting there. This R61, R33 is very similar to this R21, R33. This R61 is 1 year, where you actually define the problem, and then you get 4 years to do your trial. The R34, as I mentioned before, is one that I think is hard to get. Sheila, you've got an R34? Yeah, so Sheila has been successful in getting one of them. They're tough. I mean, I have to say that they're probably the toughest ones. They have the most latitude because if you can actually document, in other words, if your reviewers on an R01 say, we just don't think you've done enough of your basic work, you haven't defined your protocol, you haven't adapted your protocol, an R34 gives you 3 years and a fair amount of money in order to sort of fix all of the problems. With implementation science, though, I will say that, you really need to attack you don't want your 17-year to be the 20-year thing because you're now doing a 3-year grant to figure that out. And then the R03 is like only $100,000, but so it's not a lot of money. Let's see if I can move this forward. Did I get stopped all of a sudden, Nishan? They don't make professors very good technologists, do they? Is that the last slide? Okay. Yeah. I wasn't so bad at technology, I just didn't understand it. So anyway, that's sort of my quick and dirty, take on sort of putting together, these grants, from a 30,000-foot view, work early, work consistently, fix it as you go along, get feedback, and get feedback from people that you sort of respect. One of the things that we have at Yale, we have a Center for Interdisciplinary Research on AIDS, and some of you all are also members of that. But one of the things that you can do is if you have your grant in good enough shape in advance, you can submit it, and people will give you really helpful feedback, and I've found that to be helpful. If you don't have a formal mechanism, go to your colleagues, and go to your colleagues who will not sort of rubber stamp what you do. People who are really going to be critical, that can say, I don't understand this, or I'm not following this, I feel like this piece is missing. Wouldn't it be better if you did this? And you know, one of the challenges that that you may feel like you have is if you're like a more senior investigator and you give it to somebody who's junior but like a superstar, the junior investigator may feel intimidated by giving comments back, so give them permission to criticize you. One of the things that I often do when I'm sort of lecturing or we're having our research meetings, and I've had this happen in other countries. We were recently in Central Asia, and we were talking about what we were going to do with our project and the way we were going to do work. And I had a couple of students, they were PhD students, and they were just giving me the dickens. Well, have you thought about this, or have you done this, or like that? And of course, all of my colleagues were cringing, and they go, "Oh my God, your students are so disrespectful." And I thought to myself, I said, "What do you mean?" And they said, "Well, they suggested something, that was different than what you suggested." And I said, "If they're not suggesting something different, then they're not thinking." And so I really, I give people permission to give that feedback. And so when you're asking for feedback, give them permission to say, "I really want you to be hypercritical." Now, remember, advice is worth exactly what you pay for it, sometimes, or it can be really, really helpful. And so the stuff that I find that's crazy, I vet it with a few other people, but mostly those ideas are things that are going to be really important, and you sort of need to think about how to incorporate that. Some of the advice that really I think has been helpful for me is when somebody says, you could really move this one step further if you could do X, Y, or Z. And so people who are thinking outside the box, especially people who are coming from different disciplines, have really been very helpful. I would say that most people who are doing implementation science are working across many, many different disciplines. I mean, we've got pharmacologists on our teams, we have anthropologists, we have sociologists, we have mathematical modelers and stuff like that. And really, the language that they use and the way that they think about things are going to be really different. And that actually is your strength rather than your weakness in terms of what you're doing. I mean, you can't be so diffuse where you're trying to do everything, but the way that they're going to see things, because that's what the reviewers are. The reviewers are going to come from lots of different disciplines, and they're going to sort of make those comments. So really reach beyond that. If you're, I have to say that there's very few physicians who are on the teams that I work on. There are some, but I really like the idea that there are other people sort of giving ideas and participating in the grant. It really makes it strong, and you'll recognize that once you get into the middle of these grants, when you're having your conference calls on a weekly basis or a monthly basis, having those ideas actually will strengthen it. And I don't know if we have a talk, Luke, I know you've done this in the past where you talk about the adaptation process, but sometimes with implementation science you adapt as you go along, and having those interdisciplinary people will help keep you, sort of invested in being able to do that. What I'd like to be able to do is just sort of open it up and get some questions or comments about grants or lessons learned, or if you've had some experiences. We are going to have a couple of reviews of people's actual grants to give feedback that's related to this, so we want you to see some real life things. I've tried to cut out some pages from some of my grants just to show how things might look in terms of putting it together. And so anyway, let's open up the door. If we have a microphone, let's get some comments, questions. I can duck really well if tomatoes come my way.
Yeah, thank you so much, Dr. Altice, for this wonderful presentation. We have time for just a few short questions because we are abutting lunch. Lunch will be on level 11, one more level up than this. So are there any questions currently for Dr. Altice? Okay, great. Coming through.
And by the way, we're going to be here for a few days, and I'm also sticking around till next week because I have a grant. If anybody wants to have some one-on-one time on your grants, I'm happy to sit down and give some advice. So we can take this offline, if you will, or all out of the room. Who's got a question? Yeah.
Hello and good morning, Dr. Altice. My name is Mohammedik. I'm from International Medical University, along with International Federation of Medical Student Association. So I would like to ask two questions. The first one regarding about the key performance index. So indicators, yes. So we mentioned about outcomes. That is necessary for us to include the indicators inside the grant in terms of proposing and also pitching the ideas to the grant funders. The second point is, if we want to include the indicators in how do we feasibly measure the indicators, by quantitatively or qualitatively. Yes, thank you so much.
So, probably any intervention or any implementation process that you're going to do is you're trying to change something, whether it's a process you're going to change the number of people who get screened for X, Y, or Z. You have to have an outcome that you can measure. So for instance, if you go from 1 to 2, that's a 100% increase, but it needs to be sort of meaningful and it needs to be measurable. So you do need to say what that outcome. The outcome is the number of people are going to be who are screened for HIV is increased by 25%, but you need to have something that's measurable. Then you sort of need to ask the question, is how are you going to measure that? So the how is part of that. And so it could be something that there's a sort of an HIV registry, and you can look in a certain region that there were 200 people screened before the intervention, and at some time period after the implementing it, you went to 400 or something like that. So it needs to be measurable. And then you need to know that those data are being recorded. So you need to understand where your database may be good or bad. If people don't input things, it may look like there's no change whatsoever, right? So you need to understand that. And sometimes in implementation, we shore that up. I'll give you an example. We do scaling up of HIV prevention and I'll do a presentation on that. And we have a sort of a national database that, because the HIV prevention, every single one is recorded because they use it to reconcile the amount of medication. I know it's a pretty good measure because it has to match, but some things just don't get recorded. So you need to sort of understand the nuances of what you're measuring and how you're going to get it. Is that a measure that is accessible to you? If people aren't going to give you the database, I mean, a number of times we've tried to do work in Malaysia, but we can't get access to the database. It means that we might have to rely on something else. So it might be like a self-report. And then you sort of need to know, are there going to be some social desirability issues for that? And is that self-report very reliable? Certain things we know from the literature are pretty good in terms of not having too much social desirability, but in other settings, they may be. So yes, you need to do that. You need to be able to sort of specify what is your source of the data. And I try to give some sort of sense of whether I think that is really a high quality measure. I'll give you an example. We are, in one of our trials, we are measuring the way that clinicians do screening for multiple primary care, diseases. And so, and we're trying to only use the hard objective things. So for instance, are they screening for breast cancer? Well, we're looking in the medical record for, mammography. Mammography doesn't always get recorded sometimes because that's a hospital-based procedure, so that particular outcome is less good. But another one of the measures is screening for hypercholesterolemia. And that's a very easy measure because most of the labs relate to the clinical care. So we know that some of them are going to be better than others, and so you might sort of need to describe why there might be some differences in that. But yes, you really need to be very specific because your outcome is what you're using to power your trial. And so if you're going to have a significant difference, you can't really have a measurement bias in that. Does that help a little bit? Good, thank you.
Wonderful, thank you so much for that wonderful response. I think that we are going to postpone questions for now just because we're right at lunchtime. Lunch will again be on level 11. If you have any further questions, Dr. Altice and the team is here for the entire 3 days here, so feel free to find and mix and mingle with those people as you meet them at lunch and other places. Just a reminder, we will start the next session at 1 o'clock, which will be back in this room, Methodological and Statistical Considerations in Implementation Science with Disease Assessment. Thank you so much for the morning session.
I saw you have a question, so I'll come over to you.